our Chief Cardiologist, Cardiocare Multispecialty Hospital, Dr. Olalekan Olaleye. Put clap hands. He will not move stuff. Stuff has half-life. So when you clap, the thing will, there's a way ginger is to come out.
Thank you very much, sir. We are welcome again. And in this first lecture, we'll be going over hypertension, and someone will ask, why do we keep talking about hypertension every year? And I will say, the reason why we have to keep doing this is studies have shown that if we successfully manage hypertension, we will succeed in reducing mortality from cardiovascular disease by close to 60%. So knowing about hypertension is very, very important. And from the feedback and the patients we've gotten, we've seen that there's still a lot of challenge in successful management of high blood pressure among patients in our environment. So the approach we want to use is to use cases to be able to go through diagnosis, evaluation, treatments, and follow-up of some special aspects of hypertension, so that we'll make it as practical and as close to practice as possible. This is not going to be a big talk about prevalence, genetic, but we want to make it straight to practice like we encounter in our patients every day. So, elevated blood pressure reading, but has never been on medication. Our pulse rate was 84 beats per minute and regular. So a 46-year-old woman in the process of going for trabeculectomy had an elevated blood pressure of 142/84 and was sent to Cardiocare for evaluation. So the first question I want to ask is this patient hypertensive? I will need a volunteer to ask. Please, if I can get a microphone that can be used in the audience. This patient that is going for trabeculectomy had a BP measurement of 142/84. Pulse rate was 84 beats per minute. Previous elevated blood pressure reading, but has never been on any medication. So the question is this patient hypertensive? I want a volunteer. Thank you, sir.
No, the patient is not hypertensive.
Why, sir?
No record of previously confirmed hypertension and a single reading of 142/87 does not qualify for the diagnosis of
But in the history, it was stated that there has been previously elevated reading, though she has never been on any medication.
The readings were not mentioned, so we cannot speculate.
Okay, thank you,
These
sir.
were not mentioned.
Another opinion? Any different opinion? So, is the patient hypertensive? Let's take one more opinion before we conclude. Not you, sir.
Thank you very much. Okay. I think at this very stage, we have to know her normal blood pressure. That's her stable blood pressure from that, because I've seen people with 90, 60. They have been doing very, very fine. So using this good line, if we are to use a standard line of maybe 110 to 1D, it might not be a true definition of that. But however, if she has been fine and stable with it, and lifestyle modification has been fit for her, she has not been using antihypertensive, then that's fine. But if it's just, secondly again, who was the person managing her? Is he a cardiologist? Does he have a full knowledge of what it means to diagnosed hypertension? How many times has he taken the blood pressure? At what occasion? How many hours interval? What was her physiological state before the BP was taken? Was she on any caffeine? Was she on any painful distress? What was those things? You have to rule it out before we should just finally conclude, because people do a lot of crazy things just any money from her again.
Thank you very much. So I'm happy with the response we have so far, because before you can say someone has hypertension, you should find a state of persistent elevation of average blood pressure readings above 140/90. That is for office reading, or a self-report of previous use of antihypertensive, or a previous report of confirmed elevated blood pressure. So, persistent elevated blood pressure reading, more than one reading. So this is our first question. Is she hypertensive? Then how do you confirm or rule out hypertension? And I talked about this. Persistent elevation of average blood pressure reading, not a single reading. Our boss defined specific threshold. I talked about 140/90 for office measurement or self-reported diagnosis by a physician or a current medication for hypertension. And these are the points that was brought out by different speakers. You don't know how the previous readings were made, whether they were appropriately recorded and stuff. So at this point, it is difficult to say whether this patient has high blood pressure or not. So the next question is, what will you do for this patient if we have anybody that is on the poll? So we're told to log on to www.cardiocare.polls so that we can just get our knowledge about this. Okay, so people are saying we should check blood pressure. Someone says we should recommend an out-of-office BP check and do appropriate investigation, about 33%. Then check on the second arm. Nobody is going for that. So, okay, more people are going for an out-of-office BP check, then appropriate investigation, check blood pressure again. So in a minute. So the next thing to do for this patient, definitely you're going to do another reading during that encounter, during that consultation. And like I said, emphasis now is now on getting blood pressure reading out of the hospital in order to rule out the co-founding factor of white coat hypertension. So it is recommended that where you have the equipment to do an out of office, preferably a 24-hour ambulatory blood pressure monitoring. And where it is not available, you can do a home blood pressure monitoring after giving the proper instruction on how to do it accurately. That means you have to show the patient how to do the reading, the sitting position, look at the instrument, the cuff size, and give all the necessary instruction. So both 1 and 2 are applicable, because you can as well do repeat office blood pressure monitoring, but it is preferable to recommend an out-of-office BP check. And talking about checking on the second arm, when you are seeing your patient for the first time with high blood pressure, you are supposed to check the blood pressure in both arms, identify the side with the higher reading, and you will use that side for subsequent follow-up and also preferably in 2 different positions. Do it sitting and also do a standing blood pressure assessment. So for the patient, a 24-hour blood pressure monitoring was done for her, and we had 24-hour BP average of 117/69. Daytime average blood pressure for her was 120/70. Through this process in making a diagnosis of hypertension. So it is most likely, maybe at that 142/84, somebody might have started medication for the patient, whereas after going through the process, we find out that the blood pressure was actually normal. Maybe the news of the surgery, anxiety surrounding the surgery, and every other thing that the patient had that day was what made the blood pressure to look like what we had during that consultation. And like I said, when there is no instrument or equipment to do the ambulatory blood pressure monitoring, home blood pressure monitoring can also be done. Do blood pressure measurement in the morning and evening for 7 days, and you ask the patient to record the reading. Morning, evening, with a validated device, appropriate size. You would have given the instruction, sit for 5 minutes. The seat you are using there must be a back, both feet on the ground, no full bladder, you must empty your bladder, no smoking within the last 30 minutes. You give all those instructions, and you tell the patient to take the reading. Take 3 readings, like 1 or 2 minutes apart, and take the average of the last 2 measurements. So that gives you the blood pressure, and you do that morning, evening for 7 days, and you bring the result, and we'll look at it. So that also works, and you can use that. And for that, your cutoff will be 135/85. So any blood pressure 135/85 and above means there is elevated blood pressure. So you can, after doing that, you can now confirm that this patient has elevated blood pressure. And like I said, what ambulatory blood pressure monitoring will do for you is, like the patient we discussed had white coat hypertension, because in the hospital the blood pressure was elevated, but during the home reading was normal. And the opposite is what we call a masked hypertension, where in the hospital the blood pressure reading is normal, but by the time you do the out-office measurement, you have elevated blood pressure. So doing that, you can see white coat hypertension and masked hypertension. And so diagnosis, you have a patient with elevated blood pressure, you need to do a repeat blood pressure measurement, or you do an out-of-office measurement. And once you do your out-of-office measurements and those criteria are met, for ambulatory blood pressure monitoring, 130/80, 24-hour average. For those who want doing home blood pressure measurement, it is 135/85. Then you can now confirm that this patient has hypertension or not. Media, there are a lot of things we would have loved to show. Maybe we'll see that. So, and I said the reason why we have to do this is based on the latest studies done by Okubadejo. We used to talk about 1 in 3 person. So this is the table I talked about, that using the office, we talk about 140/90 as the cutoff, the ambulatory BP 135/85, and the home BP 135/85, the 24-hour average. The 24-hour average, that's 130/80. So once you have that, then you can confirm that your patient has hypertension. I talked about the white coat, the masked hypertension. You will have the slide, so you can always go go through it. So, and this is why I said, once you are able to do that, but if you have 160 over 100, that is where you have grade 2 blood pressure and above, at that point you can, that is after doing a repeat measurement, and you have that, you can say your patient has hypertension, but below that you need to do out of office measurements. So, case 2, okay, this is telling us about the grading of high blood pressure, so that we'll know where each one belongs to. And so, case 2, let's go to case 2. We don't have time. So, case 2 is a Mr. S.O., 56-year-old man. He presented with headache and palpitation. 56-year-old man presented with headache and palpitation. There's associated history of polyuria and passage of frothy urine. No history of diabetes. There's family history of hypertension. He hasn't taken BP medication that he was given 3 months before presentation when he was diagnosed. There's history of smoking, and there's history of alcohol intake. So the average blood pressure reading was 162 over 100. His apex beat was at the 6th left intercostal space even. Then heart sound was S4, S1, S2. His chest X-ray, abdominal examination, they were all fine. So the question is, if you can see, what are the basic investigation you will want to do for these patients? 56-year-old came with headache and palpitation. There's history of polyuria, passage of frothy urine, has history of family history of hypertension, smokes, takes alcohol regularly. Blood pressure was 162 over 100. His apex beat was at 6th left intercostal space. So what investigation, basic investigation you want to do for these patients? We have a minute to do this. "30 seconds more." He said the basic investigations, basic investigation you want to do for these patients. Okay, so most people picked electrolytes and urea, urinalysis. 2% talked about early morning and Doppler ultrasound of the kidney. Thank you. So, what are the basic investigations you want to do for your patient with elevated blood pressure? They are like 5 basic investigations recommended by the WHO. All others can be added based on 1, availability of the equipment. Other, in the urinalysis, you have 3 pluses of protein, 2 pluses of glucose. The LDL, total cholesterol, and triglyceride were all elevated. His fasting was 148 milligram per DL. He had LVH on the ECG. And he also happened to do, he did ABPM, and the result was 141.85. So my next question will be, how will you approach this patient? What will your treatment approach be for this patient? Now, we've identified that there are some evidence of end organ involvement here. We can see protein in the urine. We can see left ventricular hypertrophy on the ECG. So we already have effects of hypertension on important organs there. And we can also see presence of another comorbidity. He has diabetes. So how will this change the way you will approach this patient? Because you will know that when you are looking at the management of patients with elevated blood pressure, it's not just about the number. Because a patient with 140/90 may need very, very drastic and very intensive treatment more than a patient that has 150/90 in some cases. Because a patient that has 140/90 with evidence of end organ damage and diabetes is more at risk than another patient that has 150/100 with no DM, with normal urinalysis, with normal EUCR. So that you will know that you have to look at everything as a whole, not just the number of the blood pressure alone. So treatment, we'll talk about education, we'll talk about lifestyle modification, we'll talk about pharmacotherapy and other risk factors. So this is what I was talking about. Sorry, unfortunately the pointer is not working. That the presence and absence of other factors now determines what the level of risk is going to be. And that's why I said, when you look at a patient that has BP of 139/85 and has evidence of end organ damage, the patient is at a very high risk. Now compare the same patient with BP of 160/79 and with no risk factor. That patient is at moderate risk. So the patient with 135/89 with features of end organ damage, DM with organ damage, is at very high risk of developing cardiovascular complication. So that patient more serious, and you have to follow the patient more intensively compared to another patient. So we talked about this patient 160, there is proteinuria, there is LVH, there is diabetes. So at least this patient is on this line. From moderate to high risk or very high risk, depending on other factors that you found. So this is the way we look at. So you can't say your blood pressure is 140/90. Go home, don't eat salt, give diazepam, go and sleep very well. But the patient has diabetes. You found maybe some diabetic neuropathy, whatever. So that patient is not a patient that you give diazepam that is because you are not sleeping well. That's how your BP is this way. So this is the same table showing the same thing in a very simple way. So by the time you start seeing diabetes, evidence of end organ damage, the patient is at least on moderate to high risk, and you should take the treatment very aggressive. So I asked a question, I said, what level of risk is Mr. A? And I said the least we could put him would be C, because of the DM, some evidence of target organ damage. So he's at least moderate to high risk. Then other factor can now place him at D and E. So what will you give to him? Any blood pressure drug that is available, sedatives, and ask him to come back in 1 week for review. Methyl dopers, since that is what he can afford. Single pill combination based on risk assessment. So what will our option be from A to D? What will our option be? If you see this patient in your practice, what will your option be? A volunteer? What will our option be? So what will you choose? Are you going to give him anything that you have? He can only afford methyl dopa. Or, like I said, I didn't sleep well. That's why the blood pressure is like that. And I used to tell my patient then, that means everybody in Nigeria should have high blood pressure, because I don't think there's anybody that sleeps well in this country. If it is not insecurity, by the time you think of dollar exchange rates, you will be awake. So by the time you are choosing your medication for this patient, you have to assess the risk. Because what's the point of giving methyl dopa? Methyl dopa will bring down the blood pressure, but what will it do about the target end organ damage that the patient already has? It's not going to do anything about that. The only thing it's going to do is the patient is going to be happy. My blood pressure is now 120/80, while the damage to the kidney is going on. The damage on the heart is going on unchecked. So, when will you determine to give your patient treatment? For every patient with elevated blood pressure, all of them must be on lifestyle modification, irrespective of the level of the blood pressure. Reduce salt intake, increase level of physical activity to at least 150 minutes in a week, increase intake of fruit and vegetable, dash diets, stop smoking, reduce alcohol intake. Those are basic for everybody. Then drug treatment, like I said, now depends on other factors. So if you have somebody with grade 1, which is 140, 150, 89 to 90, if there is no other risk factor, if there is no evidence of end organ damage, okay, you can say, let's do lifestyle modification, come back in a month and let's see. But when the patient comes back to you after a month and the blood pressure is still greater than 150/90, please don't let him go again for another 1 month. Start the patient on medication. And when you now find all these other things we talked about, at that point, presence of DM, other important risk factor, end organ damage, start your patient on medication and aim to get your blood pressure less than 140/80. So you want your blood pressure to be between 120 to 130, 70, 79, as long as the patient can tolerate it without any symptom. And that is what is on this table. And what are the drug classes? I said as simple as A, B, C, D. So that is what. So A is the ACE inhibitor or ARB. B is our beta blocker. C is our calcium channel blocker. D is our diuretic. So that's why I said as simple as A, B, C, D, that can be combined to give your patient a good BP control. Then we have some additional one you can use, and it is advisable you use single pill combination to improve adherence. So you have 2 drugs in a single pill, 3 drugs in a single pill. It's better than patient taking 3 different drugs at the same time. And so you want to look at compelling indication to choose your combination. Then for anybody whose BP is more than 20/10 from the baseline, you should give them at least 2 medications. And in black, we talk about either using a calcium channel blocker with a diuretic, or your ARB ACE inhibitor with a diuretic, or your ACE inhibitor ARB with a calcium channel blocker. Any of these you can use, but don't combine don't combine ARB and ACE inhibitor. For example, a patient is on lisinopril and is on losartan. Don't do that. Lisinopril is an ACE inhibitor. Losartan is an ARB. That is counterproductive. What will you get? You get is side effect, complication, hyperkalemia, and all those. But you can choose lisinopril and indapamide, lisinopril and hydrochlorothiazide. And once your eGFR is less than 30 mils per minute, then a loop diuretic should come in. That is furosemide, torsemide. But in the management of hypertension without heart failure, and you should not combine lisinopril with furosemide, lisinopril with torsemide. that is only useful when your EGFR is low. And this is what we've put here, basically, to tell us you can use any of those combinations. So you can use your amlodipine with indapamide, amlodipine with hydrochlorothiazide, amlodipine with valsartan, amlodipine with lisinopril. And your beta blocker based on other indication, presence of atrial fibrillation, ischemic heart disease, you can add those. And it is better to use multiple medication at reduced doses than using maybe a single drug at a very high dose because of side effect. And you know, we talk about synergistic effect of medication because they are working through different mechanisms to help you achieve a good blood pressure control. And what are the other additional therapy? I will stop here. The slide is more than this, but because of time, I will stop here. The use of cholesterol, statin medication, is also important because we talked about other cardiovascular risks. So this patient we discussed had hyperlipidemia. So you should give them statin, atorvastatin, to get the lipids to control. The target is preferably below 100 milligram per dl. But with those people that have already established atherosclerotic cardiovascular disease like stroke, like peripheral arterial disease, you can aim for something lower. Then aspirin. In the past, we give everybody aspirin, but now it's been shown that no evidence that aspirin has a protective effect, as in when you're talking about primary prevention. But for secondary prevention, patient has had stroke, has had peripheral arterial disease, you should put them on aspirin. And like I said, these are just complications, the lifestyle modification, we talked about this, and you follow up your patients. And like I said, we'll stop here because we have hypertension in pregnancy, we have hypertensive emergency, but I think I'm out of time, except if I have more time. Okay. So I think we should take questions about this. So if there is other time, we'll go ahead. Let's take questions.
Thank you very much, Dr. Olalekan, for the wonderful lecture. I believe we all learned a lot from it, and I believe it's of utmost importance that before we commence antihypertensive medications for our patients, we'll carry out the basic investigations like we just learned about and learn to see what risk factors they have to guide our treatment. So we're going to be taking questions, please, for the next 5 minutes. So we have some of the questions online. I'll read the first one. Why is amlodipine not routinely used in treatment of heart failure? Although we still have a topic on heart failure soon, but I'll still give the mic.
Okay. So we will still talk about heart failure. So I have my teacher here that would, and my GMD that will talk about heart failure. So amlodipine not routinely used in the management of heart failure. I will just say there are guideline directed therapy. The basic one the patient must be on. Amlodipine is not there, but not that amlodipine cannot be used in the heart failures. The key drugs to be used for patients with heart failure includes mineralocorticoid receptor antagonists, that's spironolactone and the rest. Your ARB, ACE or ANI, that is in the group of the sacubitril valsartan combination, the lisinopril, the TANS. Then 3, your beta blocker, carvedilol, bisoprolol, metoprolol. And number 4, the new kid on the block, the SGLT2 inhibitor. Dapagliflozin, empagliflozin, like that. Those are the basic must-have for patients with heart failure. But for patients with heart failure with elevated blood pressure, and if these ones I've mentioned are not doing the job, you can cautiously use amlodipine. So amlodipine is not absolutely contraindicated in the management of heart failure, but you use that with caution, and that is why you need a specialist to help you make such decision. Please, let's take a question in the house. The stop has closed.
Good afternoon, colleagues. I wanted to ask, this 140-90 average, does it have any relationship with age? Say, a 40-year-old man who has 140-90, would it be rated with a 70-year-old man who also has, say, 150-90? Does it have anything to do with age, or is it absolute that once you get 140-90, irrespective of the age of the patient, is hypertension? Thank you.
Thank you very much. For diagnosis, irrespective of the age, once your blood pressure is persistently above that 140-90, the person has hypertension. Now, deciding treatment, I said irrespective of the level of the blood pressure, lifestyle modification is there. Then commencement of drug will depend on a lot of things. Then your target, your blood pressure target, when you commence treatment may also differ a bit depending on the age. But like I said, if it is tolerable, your goal is to get the blood pressure, irrespective of age, to 120 to 130, 70/79. But for elderly people, you may relax that a bit, 140, 80. Some people say it's above like 150/90. So you have to take it on a case by case approach. So for very elderly patients, 70 and above, you may relax your target. You don't want, those are not the people you want to have very tight blood pressure control because of risk of orthostatic hypotension, fall and stuff that can. But once your blood pressure is above 140/90, whether you are 80, you are 39, you are 16, that is hypertension. I think if Prof has any comments, he can also.
Thank you very much. Good morning. Let's start this way. The cutoff levels they are talking about are arbitrary. There's no magic about those levels. All right. So it is the blood pressure, the end organ damage that is most important. All right. If I have a patient with 130/80 and he shows myocardial dysfunction, I will vasodilate him. I will give him some ARBs. I might even bring his blood pressure a bit lower than what you're talking about. So let's not be fixated on levels. We are not treating blood pressure levels. We are treating a human being. And that human being is composite. And we have to take into consideration many things. Okay? And as I said much earlier, end organ damage is very, very important. And even detecting an end organ damage starts from a good clinical examination. Right? I'm not waiting for an ECG. I can pick a left ventricular hypertrophy if I do a good clinical examination. I can pick a loud P2 telling me the left side is actually in trouble and is giving the right side a problem. So again, let's go back to the basics. Let me put it this way. We should go back to the basics, the basic medical knowledge we are given, the observation, palpation, percussion, auscultation. That is the bedrock. Thank you very much.
Thank you, sir. So that's our elder talking that we should not forget her. Let me take this online question because it's a part of the presentation we didn't get to. Please, we really want to hear some approach to treatment of hypertension in pregnancy. So I'll just quickly mention, when we talk of hypertension in pregnancy, we're talking about there may be people that had with pre-existing hypertension before pregnancy. So they are hypertensive before they got pregnant, or the elevated blood pressure was found before 20 weeks of gestation. Then we have people that the blood pressure was discovered after 20 weeks of gestation. That is gestation-induced elevated blood pressure. Then we have those with pre-existing hypertension with superimposed preeclampsia. But the most important thing is about management in pregnancy is the drugs that are safe and the drugs that are not safe. So a pregnant patient should never be on ACE inhibitor or ARB. So we can do methyl dopa, you can do labetalol, you can do nifedipine. Those drugs are safe for them, and you should follow them up the same way you follow up other group of people with elevated blood pressure. Then after delivery, if it is a gestational induced hypertension, after 6 weeks, you expect the blood pressure to come down, to become normal. But if it is pre-existing, it will persist beyond that 42 days, and you need to still continue to manage. So during lactation, the same drug. Some people, if you are not bothered about reduction in the volume of breast milk, some people use diuretic, but I will still stick with the same medication that we used during pregnancy. So it's just about that for hypertension in pregnancy. Do we still have time for any other question? Thank you very much. So I hope we enjoyed this, and we'll still talk more in subsequent sessions. Thank you very much.